I want you to picture this. It's, let's say, 3 a.m. on a Tuesday. You're in the ER, and it's that specific kind of hospital chaos.
Oh, yeah.
Alarms are chirping in this, I don't know, this rhythm that feels like it's designed to spike your blood pressure. Phones are ringing. It smells like antiseptic and really old coffee.
I know that scene very, very well. And right in the middle of all that, you've got a clinician who's probably been on their feet for 12 hours straight.
Exactly. And this doctor, she's trying to stabilize a patient, but she's not just fighting the medical condition, she's fighting the admin.
The paperwork.
The paperwork. She's frantically typing into some legacy system that looks like it was built in, I don't know, 1998. She's shuffling papers, trying to remember if the patient said they were allergic to penicillin or was it peanuts. It's total cognitive overload.
It really is the bottleneck of modern medicine, isn't it? We have these amazing treatments, but the whole pipeline to actually deliver them is just clogged with data management.
So now imagine that same doctor, same chaos. But standing behind her isn't some stressed out intern with a clipboard. It's a team, an invisible, specialized team.
Okay.
One agent is like whispering a perfect summary of the patient's history into her ear. Another one is instantly pulling up the latest clinical research from last month, not last year. A third is drafting the treatment protocol, and a fourth is translating all the jargon into plain English for the, terrified family in a waiting room.
And the kicker here is none of those agents are human.
That is the scenario we are diving into today. We are doing a deep dive into something called CuraFlow AI. And I want to be really clear up front. This is not just another AI for healthcare app.
No.
The documentation explicitly calls it an advanced healthcare orchestration platform.
And that word orchestration, it's doing so much heavy lifting there.
Yeah.
And honestly, it's the main reason I was so excited to look at these sources. It just frames the whole conversation differently.
It sounds substantial. So before we get into the nuts and bolts, what's the actual mission here? Why are we looking at this specific GitHub repo and its tech docs?
We're looking at it because it represents a pretty fundamental shift in how we think about AI's utility. For the last year or so, everyone's been obsessed with the generalist model.
Right. You open up ChatGPT or Gemini, you type in some massive prompt, and you just hope the bot can be a doctor and a lawyer and a poet all at once.
The Swiss Army knife approach, yeah.
Which is useful, but maybe not what you want for, open heart surgery.
Exactly. In high-stakes fields like medicine, a Swiss Army knife is actually pretty dangerous. You don't want a tool that's just okay at everything. You want a scalpel. You want a specialist.
Okay.
So the mission of this deep dive is to really understand multi-agent workflows. We're going to see how CuraFlow breaks the job down into these small, manageable pieces and then assigns specific AI agents to handle each one sequentially.
So it's less like one brain trying to do it all and more like a relay race.
Precisely.
Yeah.
It's a relay race where passing the baton effectively is just as important as running your own leg of the race.
Okay, let's get into that concept. Orchestration. The source material brings it up again and again. To me, that implies a conductor. So who's the conductor in this scenario?
In this architecture, the software itself is the conductor. But the human is the composer.
I like that.
I mean, think about the difference between this and a standard chatbot. If a doctor uses a basic LLM, they have to prompt it manually for every single step. Here are the symptoms. Give me a diagnosis.
And you get a wall of text back.
You get a wall of text. Then you have to prompt again. Okay, now check that for drug interactions. Then again, summarize this for the patient.
So the doctor is literally dragging the AI through the process. That just sounds exhausting.
It is. It's manual orchestration.
Yeah.
It actually adds to that cognitive load we were just talking about. CuraFlow AI is designed to automate that handoff. The documentation calls it a cohesive environment. The output of the intake step becomes the exact input for the research step. No copying and pasting, no reprompting.
It just flows. Hence the name, I guess.
Exactly. And the goal, and this is stated right in the project readout, is to assist clinical professionals in an evidence-based environment. That phrase, evidence-based, that's key. It's not about generating creative text. It's about generating verifiable clinical work.
I want to drill down into how it does that, because when I was looking at the agents section of the repo, I realized this is basically a digital hospital staff. They've defined 4 really distinct agents.
And each one has a very narrow, very specific job description.
Okay, let's walk through them. Agent number 1, the nurse intake agent. The role is listed simply as summarization.
Which sounds deceptively simple.
It really does. I mean, how hard can it be to summarize a conversation?
In a medical context, ideally extremely hard. Patients are, well, they're terrible narrators. No offense to any patients listening. I'm one too. But we don't present our symptoms in neat bullet points. We tell stories.
Oh, yeah. My knee hurts, and it started around the time my cat ran away, which was Tuesday. Or maybe it was Wednesday.
And by the way, I also have a headache.
Exactly. It's unstructured, it's noisy data. The nurse intake agent, it uses the Gemini API to sift through all that noise. Its function is to extract the clinical signal from the noise.
So it picks out the important stuff.
It identifies the primary complaint, the history of the illness, the relevant vitals, and it discards the part about the cat.
Unless the cat scratched them, I assume.
Touché.
No.
But yeah, generally it's creating a clean data dump that the next agent can actually work with. It standardizes the input so the rest of the system doesn't have to guess.
So the nurse cleans up the mess. That brings us to agent number 2. This is the one that really caught my eye, the Diagnostic Lab agent. Its role is research. But the source material uses a really specific term here, clinical grounding.
Yes. If you take just one thing away from this deep dive today, let it be this concept of grounding. Okay, break that down for us, because usually when we talk about AI hallucinating, it's because it's just, guessing the next word based on training data that might be 2 years old.
Right. A standard LLM is like a library that stopped buying new books in 2023. So if a new virus emerged yesterday, that LLM doesn't know about it. In medicine, that ignorance can be fatal.
Okay.
Grounding solves this. The CuraFlow documentation highlights that this agent uses Google search grounding.
So it's connected to the live internet.
It is. But it's not just Googling it like you or I would. It's using the search tool to retrieve specific current medical sources. It's looking for peer-reviewed studies, updated clinical guidelines, recent drug trials.
It's not just remembering facts, it's verifying them in real time.
That's it. It's the difference between a medical student answering from memory versus a researcher who's actually looking up the citation. The documentation says it provides source-backed answers.
So it can show its work.
Yes. When it suggests a diagnosis, it can literally point to the URL where it found the supporting evidence.
That traceability, that seems massive for trust. If I'm a doctor, I'm not going to trust a black box. But if it says, I think it's this, and here is the study from the New England Journal of Medicine that matches these symptoms, I'm definitely listening.
Exactly. It moves the AI from being a creative writer to a research assistant. It creates a genuine audit trail for the diagnosis.
Okay, so we've got the summary from the nurse and the research from the lab. Now we go to Agent 3, the clinical protocol agent.
This is the guidelines phase. This is where the rubber meets the road.
The function listed is provide evidence-based treatment plans and perform medication checks.
This is the safety net.
Yeah.
You got a diagnosis? Great. Now what? What do you do about it? The protocol agent generates a step-by-step treatment plan. But crucially, it cross-references that plan against the patient's specific reality.
You mean things like allergies?
Allergies, yeah. Other medications they're already taking, pre-existing conditions. If the research says prescribe drug X, but the patient is already on drug Y, and those two interact badly, a tired human doctor might miss that. This agent is designed specifically to catch it.
It's almost like a logic gate, validating the feasibility of the cure.
It's performing what we call a contraindication check. It makes sure the solutions doesn't create a new, worse problem. It's checking the math, basically.
Which brings us to the last one, agent number 4. And I have to say, in a tech stack that's all about logic and data, this one feels the most human, the patient educator agent.
I love this addition. It really shows that developers understand the entire life cycle of care, not just the diagnosis part.
Its role is communication, and the function is to translate clinical jargon into compassionate patient instructions.
Compassion is the key word there. It really is.
It really is. I mean, we've all been there. You leave the doctor's office, you're worried, you're holding a piece of paper, and you realize you have no idea what idiopathic means, or whether take with food means a single cracker, or, a steak dinner.
There's a huge issue in healthcare called non-compliance. And it sounds like the patient is being rebellious, but usually it just means they were confused, they didn't understand the instructions.
Right.
Doctors speak Latin, patients speak English. There's a huge translation gap.
And doctors often just don't have the time to sit and explain the biology for 20 minutes.
Or they've explained it 500 times that week and they're just on autopilot. The patient educator agent takes that complex protocol that the last agent generated and it rewrites it. It changes administer 50 milligram orally bid to take 1 pill in the morning and 1 at night by mouth.
And it does it with a specific tone. The source mentions the tone should be reassuring.
Which matters.